privilege to invite Dr. Kapil Zipre, the president of our society.
Okay, good morning. Straight to the topic. Hypothermia is one of the concern in post-arrest situation, and so many years we are discussing. And my whole talk will cover the hypothermia in past and what is the present situation. So before that, one should understand what is the outcome following the cardiac arrest. Whenever any patients get arrested, what is the outcome? We are mainly concerned with the neuroprognostication. And if you go to the evidence, the survival of the in-hospital cardiac arrest range from 3% to 27%. It's very poor. And median survival rate for the discharge is about 15%. It gives you the idea what is the status of the post-cardiac arrest situation. And after in-hospital cardiac arrest, survival rate up to 24 hours is 13 to 59% for the worst. And if you say the survival rate after the out-of-hospital cardiac arrest is 7% only. So we are concerned with the out-of-hospital cardiac arrest, in-hospital cardiac arrest, in-hospital cardiac arrest survival at the 24 hours. And let's see how we can do better and what happens in the past. Before going into the depth, just go through the basics. What is the definition of therapeutic hernia? Therapeutic hypothermia, it's a research council states that hypothermia can be defined as a condition where the core temperature is less than 35 degrees. That is hypothermia. Initially, they were divided into the mild, moderate, severe on the basis of the temperature, like mild is 35 to 32 degree, moderate is 32 to 30 degree, and severe is 30 degree. In whom you should do the hypothermia? There are the certain categories of the patient where you can definitely consider the hypothermia, like those who patients after the cardiac arrest resuscitation get the spontaneous circulation, who are there in a still coma, that means they are not doing the purposeful movement following any cardiac arrest, whether it is out of cardiac arrest or in hospital cardiac arrest due to the cardiac causes. These are the common conditions where you can consider the hypothermia. What is the ideal timing? Ideal timing is immediately after the hospital arrival or within 6 hours of the cardiac arrest. How you can do the cooling? Either you can infuse the cold saline, 4 degrees centigrade cold saline IV through the IV lines, or you can do the external cooling with the packs, or nowadays there are the very high professionally blankets are available. That's what the therapeutic. How it helps? It helps by reducing the overall metabolism. It helps by reducing the oxygen consumption. It helps by reducing the CO2 production. And that is how it helps to reduce the cerebral ischemia, and you can expect the or anticipate the more neurological recovery, and that's what the whole purpose of hypothermia. So these are the landmark tests. These are the landmark tests in 2002 in NAGM, whether the hypothermia was strongly recommended in a post-cardiac arrest situation. There are 3 conditions they consider, like a pre-hospital arrival, that means in the ambulance when the patient had arrest at the site and when you are moving towards the casualty, that is a pre-hospital arrival. That is the one situation. Second thing is out of hospital, but when you arrived in a hospital, that is second. And third one was in-hospital cardiac arrest. Now, if you go through the evidence, they were strongly recommended in favor of the improving the outcome as well as the mortality. The International License Committee on Resuscitation in 2006 and 2010 revised the guidelines. They gone through the literature and the evidence available on the hypothermia, and what they found, there was a strong recommendations or evidence available for the pre-hospital cooling. Pre-hospital cooling means when the patient is in ambulance, they used to give it to the intravascular, the cold saline, 2 liters of the normal saline at the 4 degrees centigrade you can infuse, and you can achieve the hypothermia of the 32 to 34 till he reaches the hospital, and that seems to be beneficial in terms of the neuroprognostication. Then in hospital arrest, that means out of hospital, when you arrive in a casualty or emergency department, within 6 hours you can offer the hypothermia. Again, there are the 2 classes, VF and pulseless VT and non-arrhythmia arrest. In both they found there was a benefit. So there in 2010, American Heart Association updated the guidelines, and according to these guidelines, they suggested hypothermia moderate 32 to 34 degrees centigrade is recommended for the out of hospital arrest as well as the in hospital arrest, and also it may be useful in a conditions where in the pre-hospital conditions when you are traveling to the nearby ambulance. So what were the recommendations in 2010 American Heart Association? These are the induced hypothermia up to the 32 to 34 degree. You have to understand the consequences of the hypothermia. When you are cooling the patients, there are many complications are happening. There is arrhythmias are happening. There is a bleeding is happening. There is a shivering is happening. Then it may increase the further intervention. But up to 2010, there was a recommendations as per the American Heart Association, and the subgroup of the patients with out of hospital VA purposeless VT cardiac arrest, those were the candidate, they get the beneficial. Post return of the spontaneous coma, they got the beneficial, and most of the other comatose patient after the cardiac hospital, that means the in-hospital cardiac arrest. So there was a quite strong belief. This was one of the strong recommendation in critical care area. The hypothermia is one of them. Otherwise, there are so many recommendations in critical care management which do not have such a strong recommendation in favor of any intervention. This was the situation up till 2010. Now what is happening recently? So recently in 2010 to 13, the concept is changing. Now we are moving from hypothermia to the targeted temperature management. The concept is changing from cooling the patient to the targeted temperature management. What do you mean by targeted temperature management? Targeted temperature management means is a mild hypothermia. If at all in certain selected group of the patients, if you are offering the hypothermia as per the evidence base, then you are going for the mild hypothermia, that means 33 to 36 degrees centigrade. And it is not the only hypothermia. In targeted temperature management, you are concerned with the fever. The fever is bad for the brain. So you are not only concerned with the mild hypothermia, even you should see that patient should not be febrile, or patient is having the fever, treat them aggressively. So the concept of the hypothermia is changing towards the targeted temperature management, that is in favor of the either mild hypothermia, so moderate and severe are out, and then you are going towards the management of fever. Mild hypothermia, when somebody says 33 to 36 degree, again the next question will come, how much, 33 or 36 degree? Again you have to select the patient. I use the terminology selected patient. What do you mean by selected patient? Suppose your patient is having the bleeding risk, then you will go towards the 36 degree. You will not go towards the 33 degree, because the more the hypothermia, the chances of bleeding will be more. So if your patient is a severe trauma and coagulopathy, you will not go ahead with the 33 degree. You will go towards the 36 degree. But on the other hand, your post-cardiac situation, you are worried about the raised ICP and the cerebral ischemia, then you move towards the 33 degree. So you are selecting the patients on the basis of the patient's clinical diagnosis as well as the complications and your anticipation of the complication. You are targeting your temperature range 33 to 36 degree. And if you see the targeted temperature management or in the hypothermia, there is no survival benefit in between the 33 to 36 degree. So you can easily go up to the 36 degree. The one of the major advantage of the 36 degrees is that the chances of the shivering, bleeding and other complications are less. So you are landed with the less sedation, less paralyzing agents, you are landed with the less complication, and when in the phase of the rewarming or when you are coming out of the that patient, you are in a better situation to do the neuroprognostication. So if you see this temperature target temperature management evidence, there is no major difference in terms of the survival in between 33 to 36 degrees. So you can easily go, you can select your temperature as per your clinical condition, and even there is no difference in between the neurological outcome. So now the evidence is in favor of the 33 to 36 degree. Then pre-hospital. In before 2010, there was a strong recommendation or whatever the evidence was available in favor of the pre-hospital cooling. But this trial, the pre-hospital cooling in 2000 JAMA, this was done almost they have done the post-cardiac arrest patients were more than 5,000, and they were divided into the two groups. There are more than 1,200 patients, 583 in a VF and 776 in non-VF. And what they observed, there is no benefit in terms of the survival as well as the neurological outcome if you cool the patient in a pre-hospital area. What they did, they infused the 2 liter of the normal saline, 4 degrees centigrade normal saline during the pre-hospital phase. But what they observed, the chances of the rearrest are more in the pre-hospital group, as well as the chances of the pulmonary edema, complications like a pulmonary edema, because the rapid infusion of the fluid in an ambulance was resulted into the more complication, which were cured by the positive pressure ventilation. But this were the adding the complication without any survival as well as the neurological outcome benefit. So now there is no recent evidence in favor of the pre-hospital cooling of the patient in a post-cardiac arrest situation. And there is even no difference in between the neurological status in the both group, whether it is a VF or non-VF group. So on background of this recent temperature targeted temperature management evidence as well as the pre-hospital care management cooling this thing, now there is a change in the guidelines from the 2015 American Heart Association. What now they are saying? Then now they say they use the terminology, rather than using the cooling the patient or hypothermia, use the targeted temperature management, that is a TTM terminology. This data was combined from the very less evidence available whichever, but one large randomized trial was in favor of the mild hypothermia. And what they conclude, to reduce this, if you do the mild hypothermia or targeted temperature management, that means not only the hypothermia, you have to concern with the fever in post-cardiac arrest situation. They reduce the mortality, they increase the neurological function. You have to continue the targeted management in between 33 to 36% as per the selected group of the patients on basis of the clinical condition. Maintain hypothermia at least for 24 hours and do the angiography and other techniques as per the necessity. This was another in 2015 NEGM trial, the therapeutic hypothermia after the out of hospital cardiac arrest in children. This was a specific subgroup they checked in the children's group, and almost 60 children were eligible for this trial, and they found that there is no significant difference in between in terms of the mortality as well as the neurological outcome in even children's in terms of the hypothermia. And the last, this was a recent NEGM trial, the utility of the hypothermia in status epilepticus. All of us know in status epilepticus every minute, every second matter. Every minute there is a number of neurons are dying. And now by definition of status epilepticus, if the conversions are staying more than 5 minutes, you are landing with the more and more neurological damage. So this trial was aiming whether hypothermia helps in status epilepticus who are on ventilator. This trial was particularly on the status epilepticus patients who are on ventilator, whether your hypothermia benefits in terms of mortality as well as the neurological outcome. Almost 270 patients were enrolled, and this was mechanically ventilated patients versus standard care of the status epilepticus. And unfortunately, this trial is negative. There was no benefit of hypothermia in status epilepticus who are on ventilator in terms of the neurological outcome. So to summarize the past evidence as well as the present evidence, hypothermia post-cardiac arrest is a standard care for the all correctly selected patients. Again, you have to be very clear, corrected selected patients with the return of the spontaneous circulation. Cooling should be initiated as soon as possible, but can be delayed until the arrival in hospital. That means no need to rush or no need to go ahead with the pre-hospital cooling in ambulance. Targeted temperature management is a concept, that means 33 to 36 degrees centigrade. Again, you have to select your patient in terms of the anticipated complication as well as your judgment. 36 degree and 33 degree, there is no major or no significant difference in the mortality as well as the neurological outcome. Duration of the hypothermia should be 24 hours, but needs to be evaluated. There are few trials are coming up with the 48 hours, but at present the evidence is in favor of the 24 hours. And there is no substantial evidence in benefit of therapeutic hypothermia in indications like status epilepticus or cardiac arrest in children. These are the subgroups. Thank you. Thank you very much.